We're now going to move on and talk about the ECG changes in a myocardial infarction. We're going to start off with the ST segment. Before we begin, it is important to mention that you have to interpret the ECG in the context of the patient's symptoms. Now, in a STEMI, we have an acute occlusion of a coronary artery with a thrombus. This will lead to the interruption of blood flow to the myocardium and therefore transmural ischemia. Low oxygen levels means low levels of ATP, and the cells begin to leak potassium into the extracellular space. So this is the area of ischemic myocardium, and it's relatively positive due to the potassium ions with respect to the nearby healthy myocardium. This voltage difference between the ischemic and the healthy myocardium is going to show up as an ST elevation on the ECG. Conversely, if we have an electrode on the opposite side of the heart, we're going to see ST depression. Now, this is what we call reciprocal changes, and it's very important because it dramatically increases the specificity for diagnosing a STEMI. So what you're going to need is ST elevation compared to the TP segment in two adjacent leads and, if possible, reciprocal changes. Now, in an NSTEMI, we have ST depression, and we often also have T-wave inversions, which we'll get into in the next video. In an NSTEMI, there's a restriction to the blood flow, which causes endocardial ischemia. So the underlying endocardium is affected to a greater degree than the overlying epicardium, which receives the blood first. Now, like in our previous example, a lack of oxygen will cause a reduction in ATP, leakage of potassium, and therefore there'll be a voltage difference between the ischemic and the normal healthy tissue. Now, the voltage difference in this case is going to be from the relatively positive endocardium to the relatively negative epicardium. So a lead overlying the epicardium is going to pick up a negative voltage difference, and therefore ST depression.